రికార్డింగ్ స్టార్ట్ చేస్తున్నారు.
స్టార్ట్ అయిపోయింది. స్టార్ట్ చేద్దామా మేడం? దిల్ కీప్ జాయినింగ్ ఇన్. మనం ఇంట్రొడ్యూస్ చేద్దాం. శ్రీమన్, దీనికి శాంత మేడం వీడియో ఏం లేదు కదా?
నో మేడం, దీనికి ఏం వీడియో లేదు.
ఓకే,
సో స్టార్ట్ చేద్దామా?
యా మేడం, స్టార్ట్ చేద్దాంగా. పీపుల్ హు జాయిన్డ్ ఆన్ టైమ్ షుడ్ బి బెనిఫిటెడ్ కదా.
Yeah. So good afternoon all participants for the Dheera OBGYN program. So Vijayawada Obstetric and Gynec Society has decided to have this program mainly to know what is violence against women and how do we recognize, and then when a patient comes or a woman comes with the violence, how do we go about with the examination? Can we just avoid or can we deny the examination? That is one part. And how do we go about it and the collection process? And how do we counsel the patient, both mentally and also do we need any like psychiatrist support? All these things we will be dealing in the next 2 hours. And Dheera program is very close to our Obgyns. We have done 39 sessions in the schools, in the Dheera school sessions, and almost we have 25 and odd master trainers. And this is something like a record for Vox, and also looks like we are the first among the societies in Foxy to do this program. And apart from this, we are also very much interested in the adolescent health, and we have covered like 15,000 students, nearing 15,000 students regarding the adolescent health programs. So apart from the Dheera school programs, adolescent programs, we also would like to have this OBGYN program, so that all our Obgyns are well versed with the problems of violence that are faced by the pregnant woman and newborn, from the newborn to any aged woman to say. So let us start the program with Dr. Lata's talk on overview on violence against women. Yeah, Lata, I think you need to share the screen, Lata. And the other thing I would like to remind is, please complete the post-test so that you'll get the certificate from Foxy and the UNICEF. So otherwise, like you will not be given the certificate. So please be till the end of the session and then do the post-test. షేర్ అవ్వట్లేదా స్క్రీన్? Any problem, Lata?
Madam, her audio is not visible and she has shared, but that screen is not visible to us.
Lata?
Rejoin madam, sorry, Zoom lo.
Lata garna?
Lata madam, sorry.
Yeah, Lata madam, malli rejoin avutaru nanu oka nimisham. $63 logins still now, madam.
Good number.
Yeah.
Lata madam,
I can't hear you, Lata garu.
Madam, permissions adugutundi Zoom lo ani first login ayetappudu adi accept cheyapothe itla vastund. Okasari re-login avvandi madam. Appudu malli permissions accept cheyochu.
ఇయర్ ఫోన్స్ ఏమైనా పెట్టుంటే తీసేయండి లత గారు. వి స్టిల్ కాంట్ హియర్ యూ. ఇయర్ ఫోన్ డిస్కనెక్ట్ చేయండి సిస్టమ్ నుంచి.
Now,
Yeah, we can hear you.
We can hear you.
We can hear you.
so I'm sharing my screen.
Yeah.
Disabled host, disable the participants' screen sharing.
Shriman.
Yeah,
ఒకసారి ట్రై చేయండి మేడం. ఇప్పుడు ఐ మేడ్ యూ పోస్ట్.
Yeah, we can see your screen. Put the Dheera PPT on the
1
screen.
minute. Yeah. Now okay.
Yeah, full
Yeah,
screen.
Yeah, full screen. Yes.
Now okay.
Yes, yes.
So I think all of you have done the pre-test and registration. So I'll be dealing with the overview of. Hello.
Yeah, Lata garu.
ఏంటి స్లైడ్ అవ్వట్లేదు?
Slide change అవ్వట్లేదా?
మీది యారో ప్రెస్ చేయండి మేడం. నెక్స్ట్ యారో కానీ ఎంటర్ కానీ ఏదైనా ఒకసారి
ప్రెస్ చేస్తున్నాను.
మౌస్ ని డబుల్ క్లిక్ చేయండి మేడం. మౌస్ ఉంటుంది కదా
ఎక్కడ?
మౌస్ డబుల్ క్లిక్ అంటే చేయండి.
చేశాను.
Yeah.
ఇది లాస్ట్ లో ఉందా? Okay. So I'll be talking on the overview, violence against women. So these slides are prepared by the Dheera OBGYN core group. Sincere thanks to all of them who have helped collaborate all these project by Dr. Shantakumari, Dr. Kiranmay, etc. The gender-based violence is what forms of gender-based violence you experience, have the women and the children been experienced. You must have come across such stories in your OPDs. Where can women and girls experience gender-based violence? Just think about this. And which age groups may experience this gender-based violence? So all of us must have come such cases in our OPDs where the patients have shared their experience of violence against them from their childhood to the adulthood. So what do we understand by violence against women? The violence against women means any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such acts, coaction, or arbitrary deprivation of liberty, whether occurring in public or in private life. So violence against women encompasses the physical, sexual, and violence, psychological violence, not only in the family, but also in the community, and which is perpetrated by condoned by the state, wherever it occurs. So there are different types of violence. It may be physical violence like kicking, biting, slapping, beating, strangling, etc. Psychological violence, this is preventing a woman from seeing family and friends, belittlement or humiliation, economic restrictions, violence or threats against cherished objects, or other forms of controlling behavior. Sexual violence is a forced sex using physical force, threats, intimidation, forced participation in degrading the sexual acts, denial of the right to use contraceptives or measures to protect against sexually transmitted diseases. Intentionally inflicted injuries are often disguised as accidents. Most of the patients, they don't reveal what has happened. They try to hide the different injuries as a form of accident, though it would have been because of the violence caused by her husband or family members. At times, women are seriously injured and in some cases die as a result of their injuries. As you can see in the map, almost 30% of the women globally have experienced physical or sexual violence. As you can see, in India, almost 40%, that is 37.7%, are affected by this violence. And it's present globally. It ranges from 25 to 30%. So the gender-based violence is underreported. And the cases which we come to know are just the tip of the iceberg. The Demographic and Health Survey data from 24 countries collected between 2004 to 2011 has disclosed that 40% of women experiencing gender-based violence previously disclosed this to someone, but who never took any further action. But only 7% of the reported to a formal source. And there is wide regional variation is there. In India and Southeast Asia, it's only 2%. And in Latin America and the Caribbean, it is almost 14%. So violence against women, the cycle of abuse, as you can see here, this violence is experienced by the female from the pre-birth itself in the form of sex selection, abortion, effects of battering on pregnancy and childbirth. In infancy is the form of female infanticide, physical, sexual, or psychological abuse. In the girlhood, like child marriages, female genital mutilation, physical, sexual, and psychological abuse, incest, child prostitution, and pornography. And as the girl reaches to adolescent age group, she is forced to trafficking, honor killing, partner violence, marital rape, dowry abuse, murders, abuse of women with disabilities, rape, sexual harassment, forced prostitution, and pornography. Even this leads further to forced pregnancy. And there is also acid throwing and date rape, economically coerced sex, incest, sexual abuse in the workplace. So almost 20% of women experience child sexual abuse. And as you can see, 60% of the women globally are married before 18 years. And 50% of the child marriages occur in South Asia. And 125 million women in 29 countries in Africa and Middle East experience this, what you call female genital mutilation. And almost 1,957 women in Pakistan were killed in the name of honor killing between 2003 and 7. And almost 11.4 million women are trafficked globally. And 30% of experienced the intimate partner violence. 7% sexually assaulted by someone other than partner. So you can see the huge numbers in which the women are being assaulted, especially by the intimate partner or sometimes by the other family members or some strangers also. So what are the health impacts of gender-based violence on the individual? It may be physical or reproductive. Physical may be acute or chronic. Acute in the form of injury, shock, disease, infection, weight loss or weight gain, regressive behaviors, not eating or eating too much. And in chronic physical effects, there may be disability, chronic pain, gastrointestinal disorders like irritable bowel syndrome, eating disorders like and sleep disorders, chronic fatigue. In the reproductive form, there might be miscarriages, unwanted pregnancies, unsafe abortions, sexually transmitted infections, including HIV, menstrual disorders, pregnancy complications, and gynecological disorders. Effects beyond the individual survival. Okay, those were the effects on the individual survival. But apart from the individual survivors, there is effect on the children of the women who experience the abuse, like higher rates of infant mortality, behavioral problems, anxiety, depression, attempted suicide, poor school performance, physical injury, or health complaints. They also experience or perpetrate violence as they become adults, because the children see all these things happening to their mother, and it has a bad effect on the mental development of the child. And in the same way, there is a negative effect on the families also. There is fractured family relationship, and the house becomes unstable. There is co-occurrence of the violence. There is poor collective health and coping up. And there is also effect on the community and the society in the negative way. The cost of services incurred by the victims and families in the form of health and social and justice, etc., is also becomes a burden to the woman. There is loss of education and potential development and contributions by the child as they become an adult. There is perpetuation of violence in the community. There is higher crime rates, and the burden on safety and justice sector is also more. So all these things even affect not only the family and the children of the woman, but also of the community and the society as a whole. So where and how do violence and HIV intersect? So the HIV infection may be a direct transmission through sexual violence. depends upon the different types of sexual exposure. There is presence of other sexually transmitted infections and the degree of trauma also. The indirect transmission may be through sexual risk taking, like violence intake is linked to increased risk taking, like multiple partners, non-primary partners, etc. In the indirect transmission may be through inability to negotiate condom use. Women find it difficult to suggest or insist on condom use in face of or threat of violence. So all these things leads to, this violence leads to more exposure to HIV infection. In summary, as you can see in the summary, the intimate partner violence leads to physical trauma, which leads to injury of the musculoskeletal, soft tissue, genital trauma, and others. And also, this leads to psychological trauma or stress, which leads to mental health problems like post-traumatic stress disorders, anxiety, depression, eating disorders, and suicidal ability. And these leads to more substance abuse like alcohol and other drugs and tobacco. All these further lead to non-communicable diseases like cardiovascular, hypertension, and diabetes, etc. The same way, this violence leads to fear and control, which leads to limited sexual and reproductive control. There is lack of contraception. There is unsafe sex. All these further leads to perinatal and maternal health. This affects the perinatal and the maternal health, which leads to low birth weight, prematurity, and pregnancy loss. All these also causes sexual and reproductive health is also affected in a negative way, leading to unwanted pregnancy, abortion, HIV, other sexually transmitted infections, and gynecological problems. So all these are linked to one another. The final result is a bad health to the mother, as well as to the more economic burden on the family. So almost 42% of women who have experienced physical or sexual violence at the hands of a partner have experienced injuries as well. And almost there is twice as likely to experience depression, and almost twice as likely to have alcohol use disorders. 16% are more likely to have a low birth weight baby, and twice as likely to have an abortion. 1.5 times more likely to acquire HIV, and 1.5 times more likely to contract syphilis infection, chlamydia, or gonorrhea. And almost 38% of all murders of women globally were reported as being committed by their intimate partners. So almost 4.5 times as likely to attempt suicide. They have a tendency to attempt suicide. So we'll take a look on the few statements. You think it over and decide whether it's a myth or a fact. Statement 1, intimate partner violence is more prevalent among poor women and girls. Is it true? It's a myth. Studies show that gender-based violence can happen among women, among people of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, and friends also. So it's a myth. Another statement, majority of sexual violence against women and girls is perpetrated by strangers. Even this statement is a myth. Studies consistently show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. Globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. It is safer for a woman to leave a relationship with an abuser than to stay. It's a myth, they say, like violence often continues and may even increase after a woman leaves her partner. In fact, a woman's risk of being murdered is greatest immediately after separation. This is one way of thinking. Other way is it's better to leave the relationship with the abuser than to stay. That is, I think that's the most safer way, safer part of the woman. So gender-based violence is a serious human rights, health, and development issue impacting survivors, their families, and the health and development of the entire communities. So as already said, after completion, you please complete the posters and feedback so that you will get a certificate will be awarded from the UNICEF and the FOXY. Over to you, Dr. Sushila.
Yeah. Thank you, Lata, for detailing about the magnitude of the violence against women, and also regarding the physical problems and the reproductive problems that the woman has to face, and also the burden on the society. Thank you so much for elaborating on all these aspects. Now we go on to the second topic, how to approach a woman facing violence. So this will be dealt by Dr. Chandana. Dr. Chandana, over to you.
Madam, can they make me a host, madam, so that I can share the screen?
Shriman? Shriman?
Madam, you already host, madam.
One participant can share screen at a time, it's coming.
Chandana garu, did you log in through multiple devices?
No.
And you are the host. Even I can see you as the host.
When I click the share screen option, it's showing one participant can share screen at a time.
So I need to log. I
Maybe Dr.
Start
Lata
the
has
share.
to log out. Yeah, maybe Dr. Lata has to log out.
No, Lata garu, you have already stopped.
I stopped sharing.
Yeah, you have stopped sharing the screen. Shriman?
Yes, madam.
I think you need to look into the problem, otherwise.
Yes, madam. Yes, madam. Madam, okay, try again, madam, because I removed and I gave an access. I made you co-host.
Okay.
Or else you can rejoin in the meeting, madam.
I
Yes,
think
yes.
I can.
Yeah,
Yes,
we
yes,
can see your
Chandana.
screen.
You can
Yeah.
see it.
The fifth part. That is the fifth one, I think. Yeah, Chandana, the upper one, I think you need to open.
Yes, ma'am, but it's not opening. I don't know.
It is in the shortcut. Just see the lower part. It says it is in the shortcut format. Maybe that is the problem.
Madam, will anyone share the screen then?
Yes.
Lata, you'll share the screen?
Yeah. You stop sharing then.
Yeah.
The second topic, no?
Number two.
How to approach. Okay. Okay, Chandana.
Yeah. Thank you. Good afternoon to all the Voxians who have joined this Dheera program on OB-Gynec. Thanks, Sushila Madam and Dr. Sailaja for this opportunity. My topic for the day is how to approach a woman facing violence. Next slide. Thanks to Shantakumari Madam, Ajay Bharadwaj Sir and Kiranmai Madam for this wonderful modules to reach out the obstetrician and gynecologists. Today we shall see why actually do the survivors not seek help. Because always it has been from history noted that victims are always blamed about their attitudes. They feel that it is a shame to report to a doctor or to a friend or in the community also. Still they feel it is a stigma for them, and there is always a feeling in them that they fear that the confidentiality of the event shall not be maintained and it shall be publicized a lot. And they're also scared of the inappropriate services in the rural areas. And they always feel that the perpetrator has anyway done the offense and he'll always find a way to save himself. That's the reason why the survivors actually don't seek help. Next slide. So we as healthcare providers form a part of this important triangle wherein we can serve and save the survivor along with the family, along with the friends, along with the community and the healthcare provider. Here we stay. Next slide. So as we all know, the family is the first important part wherein the survivor will be helped, the friends and the community. It should always be discussed with all the caregivers that the victim should not be held responsible for the assault. It's always said that why should you go there? Why did you go at that point of time, at that point of day? And that's the reason why you landed up in this trouble. That is what is usually told to everyone. So these words should not be done. Recovery from the violence is always dependent upon the amount of help, support we all give and they get from the loved ones. So that's the reason why even the family or a community should not raise this question to the survivor. And it should be retreated to the family that perpetrator is the person who misused the position and it's not the survivor who has gone into that particular situation. Next slide. So the role, what we have to do as healthcare providers is all women are likely to seek health services at some point of time in their lives. Healthcare providers are the most important women who are trusted and we mostly play like role models in a community. So when the survivor comes to us, it's our utmost duty that we take care of them. Violence is an underlying cause of injury and ill health. Next slide. Role of healthcare providers in creating an enabling atmosphere and establishing trust is the most important thing. So you always have to make sure to speak to the survivor always in a private space. Suppose the survivor has come to you with the attendance. In fact, the perpetrator might also be present sometimes. You have staff nurse with you, you have some other people around you. Never you should start speaking to them in that point of time. Make sure you give space to them, make a private space to them. Recognize her courage and first tell her that it's very good that you have crossed the barriers and come ahead to talk about all this to us. Recognize the dilemma usually faced by the survivor and always tell that it's okay if you would not have reported to the police. It's not a crime that you have done. We still have some time. Let's discuss what to do. Assure the survivor that the treatment will not be compromised just because you haven't reported to the police and you have come here. Inform the survivor about all the resources which are available, the legality issues, the right of becoming a victim, what all victim can do, and give an informed consent about, inform her about all this and let her take an informed decision about all this. Next slide. So the healthcare professional should prepare the survivor for an internal examination. This is the most important thing. When you are talking to her, you have to take her into confidence. We can look at the picture here, sometimes not just talking. A hand on her shoulder or a hand in hand they'll start gaining so much of confidence on us. This is how we have to take them under our control and tell that we are the person where they can start talking about what actually happened. And in the same way, we can prepare them for an internal examination also. So we have to first explain to them what are the various stages of the examination, not just start doing a pervasive examination. And it's always rational enough to tell what an X-ray means, ultrasound means, and age estimation means, and why she has to undergo all these tests. Next slide. Addressing the survivor's emotional well-being is the most important part of our role, and recognize the survivors may present varied emotions. So you have to encourage the survivors to express her feelings, encourage the survivors to seek crisis counseling, and compulsorily when you're talking to her, this is the most important thing, is what you have to do is you have to assess for the suicidal tendency they might be having, and you have to assess a safety plan for her. And it's always important to involve the family and the friends around her in this healing process. Next slide. So these are the couple of sentences or words which might come from your talk, which will encourage or give lots of confidence to the survivor. Here are a few of them. Take your time. Share only what you would like to. I can imagine that must have really been hard on you. It takes a tremendous amount of strength to share what is happening to you. Remember, you're not alone. How do you think we can help you? All these are the words probably which have to come from your talk. Next slide. The very picture of how we are sitting and talking to them will play a very important role in helping out the survivor. Always sit in a position, open position, lean forward, make an eye-to-eye contact, and stay relaxed, and make the survivor also feel relaxed. Next slide. Supporting gender-based violence survivors using the LIVES approach. L is listen, I is inquire, V is validate, E is enhance safety, and S is support. Next slide. So what is shown here is most importantly is we always tend to hear just with our ears. This is not just important for these survivors. You always have a heart which always cares to them and respects them. That is what they expect from us. So with your ears, with a caring and a respectful heart, and with an eye contact, wherein your attention does not get divided, and they always feel that you're attentively looking at them and involving in their situation. So use verbal and non-verbal means also sometimes to communicate with them. Like I told you, what you probably might have to put a hand on their shoulders. Always ask open-end questions and stay focused to them. And sometimes you might have to use good body language, and eye contact is the most important thing. And what you have to avoid is don't give them a leading question or a compound question. Next slide. These are some of the do's and don'ts which we have to do while listening to them. How do you have to act? What should be your attitude, and what you have to say? Be patient and calm. Let the client tell their story at their own pace. Don't pressurize her to tell her story. Let her know that you're listening to her through verbal and not non-verbal things you have to do. Probably that's what you might have to tell. Don't look at your watch or look at your laptop or a telephone or keep WhatsApping to some other person when you are listening to them. And acknowledge her that we are listening to her. Don't judge what she is telling. Don't judge what she has or has not done. Okay. Give her the opportunity to say what she wants. Like we have to probably tell, how can I help you? Don't assume that you know what is best for her. Most importantly, don't interrupt her while she's talking. Next slide. Best part is listen to her in silence and give her the time to think. Stay focused on her and offer support to her. Acknowledge and respect what she wishes. Next slide. The next thing is inquire about the needs and concerns. You have to invite speech from her, invitation to speak, and open-ended questions instead of just asking her an yes or no. Check your understanding by restating what he or she says. And you ask sometimes for probably some clarification questions. This will let her involve more into your talk and help her identify and express what exactly she needs and what exactly her concerns are. And at the end, sum up to her whatever she has expressed. That will lead to lots of confidence in you from her. Okay, so next slide. So these are the things which we have to talk when we are counseling her. What would you like to talk about? What do you feel about it? it sounds as if you're really feeling angry about what has happened. Could you tell me more about that, please? Can you explain me once again? Is there anything you need or you're concerned about? Next slide. So at the end of the questionnaire you have asked, you have listened to her. Validating is the next most important thing. Validating is like, it does not mean that you try and verify the survivor story. For example, you start interviewing the perpetrator also and the witnesses also. This is not safe, and it's not appropriate also, and it's not ethical also, and is not recommended. So let's see what actually validating means. It shows that you have understood her situation and you believe in her. So it's not your fault. You need not blame yourself. Your life, your health, and you are of most important value for yourself. Everybody deserves to feel safe at home. What has happened to you does not have a justification or an excuse. And I'm worried that this may be affecting your health. It's okay, let's talk. This is the way we have to validate what all she has talked to us. Next slide. And always, its most important thing is, we as practitioners tend to become sympathetic to our patients when they tell about their stories to us. So the most important thing which we have to do is never become sympathetic to them. Always deal with this survivor with empathy. So now let's see what exactly sympathy is and what is empathy is. Sympathy is a personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is identifying with the survivor's experience through your own shoes. But empathy implies intellectual or personal understanding, and it leads to a professional distancing from the survivor. It involves compassion and leaves room for empowerment of the survivor. And this is what is needed at the end of this. So always deal with these patients with empathy and not with sympathy. Next slide. So how should the provider's behavior be, and what are the possible consequences? Next. Never blame her or disrespect the woman or girls. If you do so, it will lead to additional emotional distress and trauma. Doesn't recognize gender-based violence behind chronic or recurring conditions. If you do so, woman receives inappropriate or inadequate medical care. Suppose you fail to provide post-rape care on these patients, it will lead to HIV and unwanted pregnancies and sexually transmitted diseases and unsafe abortions in these women. And never breach the confidentiality or privacy of this woman, because this will lead to more harm, and the perpetrator, if he's a family member, violence on her will start increasing. So never breach the confidentiality. And ignore signs of fear or emotional distress. The woman might later on, if you ignore this emotional part in her, she might land up in a suicide, or later she might be killed also. Next slide. So this is what we all want our patients to talk and feel confident about after our counseling. The doctor helped me feel better by saying that I don't deserve this treatment, and he helped me to make a plan to leave the house the next time my husband became violent. This is what the amount of confidence we have to give our patients. And we have to counsel them saying that women are not responsible for men's violence. You may be his excuse, but you are never the reason for his violence. Next slide. So we form an important part of this multidisciplinary approach, that is the healthcare provider, wherein we provide a psychosocial support and make them decide what legality is, how justice can be done, and how security can be provided to them. Next slide. Warm referral practices are which are needed to help these victims to reach further care. And that is what we have to do in our clinics in case we find this gender-based violence cases. Next slide. So don't forget to write this post-test and a feedback form after all the sessions are completed. Thank you for this opportunity, and thanks for patient hearing.
Yeah, thank you, Dr. Chandana.
Before you continue, some people haven't named the screens after their names. I'll request them to please put their name so that their attendance will be counted and certificate generated.
Yeah.
Go ahead, madam.
Yeah. Thanks, Chandana, for dealing about the how do we approach the woman for facing violence. So you have well said what are the approaches like lives approach, and not to be sympathetic, rather be respectful or empathetic. Thank you once again, Chandana. So we move on to the third topic, that is effects of violence against women on pregnant women and newborn. Dr. Lata, over to you to deal this topic. So our purview starts with dealing with patients who have come with pregnant patients coming with violence. So Dr. Lata is going to talk about it, and also she's going to cover regarding the violence on newborns too.
Thank you, madam. I'll be talking on the effects of violence against women on pregnancy and newborn. Have you ever seen patients in your OPD who have been victims of violence or abuse? How do they present? How have you diagnosed them? What are the common clinical presentations? Can you recollect a case scene? High levels of violence are there during pregnancy. He hit me hard in the belly and made me miscarry 2 babies. I went to the hospital with heavy bleeding and they cleaned me up. These were the words spoken by a woman who was interviewed in Peru, who had had a violence being inferred on her by her own husband. So there is a high level of violence during pregnancy, which are almost underrated because most of the women do not disclose the same with the doctor. I'll be showing a few case studies in which the death of the mother appears to be because of some medical disorder, but the actual thing is something else. So in case study 1, she is a primate, came with PROM, history of premature rupture of membranes. There is a history of prolonged and obstructed labor, and she presented with rupture uterus and in shock. And ultimately, the woman did not survive. On history taking, revealed that there was a history of brutal kicking on the abdomen by the husband and pushed violently, falling on a sharp object, which led to the death. And this death was due to the violence and not because of the obstructed labor or the rupture uterus. In the same way, another case, she's a third gravida with previous 2 living issues of 28 weeks with previous 2 sections. She came with the antepartum hemorrhage, shock, and placenta accreta was diagnosed. And for that, hysterectomy was done. 10 units of blood transfusions were given, and there was bladder involvement also. But when further detailed history was taken, what precipitated the bleeding? On history taking, the husband kicking on the abdomen was disclosed. So the cause of bleeding, APH, was not simply because of the presence of accreta, though accreta may be a cause for APH in few cases, but in this case, it was because of the violence caused by the husband. This is another case, is a woman with severe preeclampsia, and she came with unconsciousness. There was history of eclampsia with the cerebrovascular accident leading to maternal mortality. And the death was because of eclampsia. It was decided that the death was because of eclampsia. But actually, there was violence by the husband, and post-mortem revealed there was a fracture on the skull and cerebral hemorrhage. So the direct death was due to the violence and not at all because of the eclampsia. So the hidden violence masquerading as maternal disorder. In this case, she is a third gravida with previous 2 sections, previous 2 living issues with previous 2 sections, full-term pregnancy. There was a rod implanted because of the fracture of the femur, and she collapsed in front of a hotel. She was brought to the hospital in 108 ambulance. She was in active labor with severe hypertension. So emergency cesarean was done by the consent by the RMO. And on a detailed history later on, showed that she was pushed from 2nd floor 3 years ago. and now she was abandoned in labor. And this is another case in which she is a third gravida with no living issues, previous to deaths, and she is a history of previous to cesareans was there. She is now 36 weeks with severe anemia. And both times there was a history of physical violence, kicking on the abdomen brutally by the husband, followed by loss of fetal movements and IUFTs. And this is the third pregnancy in which the parents brought her home and she was treated for the anemia through blood transfusions and cesarean was done. She now has a healthy baby. And this is the sixth case. She's a sixth gravida with previous 2 living issues and by 2 cesarean sections and the history of 3 induced abortions. She came with acute hemorrhage, shock, sepsis, and incomplete abortion. There was a severe form of physical, emotional, and violence. And history of forced abortions were there, and she was abandoned. Domestic violence history was brought out through screening. Many questions were asked, and then only the violence history was revealed by the patient. And for the treatment, she received almost 4 transfusions. As you can see here, the woman was brutally hit on the head. So many lacerations are there, which almost disfigured the ear pinna also. And the uterus is a rupture uterus through injury caused on the uterus. There was a stab injury caused by the husband, who was in an inebriated form, lacerations on the face. There was perforation on the uterus, which led to intrauterine fetal death, for which laparotomy was done, and the rent was repaired. So we are in a unique position, the obstetrician and the gynecologist, a specialist stakeholder in women's health. So we are in between the perpetrator and the victim. We are to assess and provide support for women who experience violence because of the nature of the patient-physician relationship. Many opportunities comes in our lives for intervention that occur during the course of an adolescent of a girl when she is in the adolescent group, when she is pregnant, when she comes for family planning, when she comes for regular annual checkups, when she comes for some other women's health issues also. So how to elicit history? We should ask them indirect questions. Never try to ask the direct questions to the patient because they don't reveal the previous history of violences directly. The following questions may be asked indirectly. Is everything all right at home? Are you getting on well with your partner? There are different screening tools which have been prepared by different societies, like American Society, British Medical Society, by the US Preventive Severe Task Force Society, Severe Task Force. So like abuse assessment screen, humiliation, afraid, rape, kick screen, that is the HARC screen, the HIT screen, the ongoing abuse screen, ongoing violence assessment tool, partner violence screen, slapped, thrown and threatened screen, etc. Through all the screen and the tools or the scales, we have a scoring system. Depending upon the score, we can assess whether the patient is really suffering from some violence or not at home. So WHO in 2018 has recommended that all health professionals be trained in the first line response to family violence. The steps are to listen, believe, inquire about needs, validate the person's experience, enhance the safety, and offer ongoing support, which was explained by Dr. Chandana in the previous talk. The universal screening or the routine inquiry, that is asking all women at all healthcare encounters about the intimate partner violence, is not recommended. However, the WHO guidelines identify antenatal care as a setting where routine inquiry could be implemented if providers are well trained on a first-line response and minimum requirements are met. First, before inquiring, ensure the safety. The evidence on benefits and potential harms of clinical inquiry and subsequent interventions is lacking or uncertain. A minimal condition for health providers to ask women about violence is that it must be safe to do so. That is, the partner is not present there. and that identification of intimate partner violence is followed by an appropriate response. You cannot, as a healthcare providers, we should not ask the patient directly about all these things in front of the perpetrator. It might be her husband or the family members. So we should give her some privacy, as Dr. Channa has already described in detail. We should give her the privacy and talk to her with a clear language. So the detailed guidance on responding to intimate partner violence and sexual violence against women can be found in the 2013 WHO Clinical and Policy Guidelines. So as already said, post-test and feedback should be filled after this session, and then only your certificates will be provided by the proxy. Thank you, Dr. Sushila, for giving me this opportunity.
Thank you, Lata, for the elaborate talk. So unless we see the gravida, para, and the obstetric formula, we are not so attentive. So thank you for the case presentations. It was really good to bring out what all we have to look when a pregnant woman comes with violence. So we move on to the next topic. This is on mental health issues, and it is going to be dealt by Dr. Sailaja. So over to Dr.
Good evening, all of you. As part of this Dheera OBGYN program, now I'm going to speak about mental health issues. Can you see my screen, madam?
Go ahead.
Yes, Selja.
Yeah. Coming to mental health issues, elaborating a case report, Mrs. R, 26-year-old woman, was brought to the hospital with complaint of sudden abdominal pain when she was 28 weeks pregnant and married for 1 year, this being her first pregnancy. She was a normal pregnant woman like any other, booked case with regular antenatal checkup, no diabetes, no hypertension. But the point to be caught here was she was not a usual chirpy, cheerful self. She was very much depressed. That must have brought doubt in the mind of the antenatal care provider. All her vitals and examination findings were normal, but on close inquiry, she came out with history of being beaten by her husband. So the first questions which come to our mind here is, what are the details to be gathered from her? Whether we need to inform the police, how do we counsel her? What are the problems she can come across in future? How do we counsel her family? Any drugs to be suggested? And what is the aftermath of intimate partner violence? If any answers to these questions come to your mind, please put them in the chat box. Here, 3 consultations together need to take care of her. As obstetricians are the first point of contact, and a psychologist who should be speaking to her, counseling her, and a psychiatrist needs to add on with medicines if necessary. Why do we think mental support is necessary at all? Why don't we treat this as a trivial issue? This is because an antenatal woman who has come across violence can have post-traumatic stress disorder, which is perceived life-threatening or injurious to her health. She can have many implications like hypervigilance, mood disorders. She can get addicted to drugs or alcohol. She can have sexual disorders, phobic disorders. She can have GI symptoms without anything physically being identified. And she might withdraw from her society, from her family, society, and friends. The first line support is mainly to be given by us, and we have a 3-pronged approach to her. First, we must assess the risk. How frequent is this violence? How severe is it? And since how long this has been going on? We must always assess her safety. How possible it is to her to face another episode of assault from her partner. We should be screening her psychologically and assess what is the risk for her to have the thoughts of committing suicide, and what is the risk to her life from the partner. And when do we get alarmed? What are the danger signals? That should be when the violence is very frequent, there are very severe injuries, when there is alcohol misuse in the partner, when she has told you that her husband or partner is threatening to kill her, this history of sex, which is very violent, she is getting thoughts of suicide, she or her partner has access to weapon, and when the partner is extremely jealous about her relationships with others. I would say that all these danger signs would indicate to hospitalize her, but certainly we should be thinking about isolating her from her regular surroundings. And when should we think of hospitalizing her? That is when she has severe medical injuries, she has thoughts of suicide, there is risk of her being killed by her partner, when she has severe dissociative or psychotic symptoms, she is getting away mentally from her surroundings, there is mood instability, there is symptom which cannot be attributed to any physical disorder, when she is prone to harm herself, and when there is serious threat to her life. Under all these conditions, we should be thinking about hospitalizing her, and it should be always an individualized treatment and by a multidisciplinary team. And the milieu therapy means bringing her away from the surroundings where she is staying, either sending her to a parent's home or to a friend or to some other place, stabilizing her moods either by counseling or by medicine if necessary, evaluating her medically, giving her support psychosocially, documentation of any evidence which is there, and reporting any legal concerns. And this trauma recovery clinic can be very useful for such women to contact immediately, and which will enable them to come to terms mentally with that trauma and get back to their normal life by reducing the symptom, that emotional impact this trauma has on her. This trauma has so much impact on her that a woman who was very confident previously gradually loses her self-esteem, becomes less resilient. We should think about improving her social support, like who can support her emotionally, who she is close to, who she can share her experiences with. And we should, as much as possible, try to prevent another episode of traumatization. We should conduct awareness programs and capacity building programs for psychologists and counselors regarding this. And these trauma recovery clinic does not require a lot of setup. It can be set up in any hospital. And for example, this was started in 2014 at Nimhans in Bangalore. We should understand that these trauma episodes can have a lot of psychosocial impact on her. She feels helpless, as I told you previously. She loses her confidence and self-esteem. She feels guilty herself. She blames herself for the episodes. She feels shameful and isolates herself, and her bonds with her family members, her children are affected. They paradoxically strengthen the emotional tie to the person who is doing that trauma, and there's increased risk of her being killed by the perpetrator. Her coping capabilities are decreased in these victims. I won't go into the details of all this. I know as much as you all people know, but I only want to stress that here comes the role of psychologist, and he should be deciding what sort of behavioral therapy, cognitive or any variant of behavioral therapy or brief trauma-focused CBT is necessary, which can accelerate the recovery of the victim in acute cases. And skills training in effective and interpersonal regulation should be concentrated on. We should be able to educate her how that trauma episode is affecting her emotions, her relationships, teaching them to regulate her emotions and effectively express her negative emotions. Interpersonal skills should be developed related to appropriate assertiveness. She should be able to come out strongly about what she is feeling about this and what she expects from the interpersonal relationship. This treatment also includes recognizing the achievements during treatment, how she has come out of that emotional impact, and how she is able to exercise self-compassion. Interpersonal psychotherapy is important, and psychological therapy where intimate partner violence related depressive disorder or alcohol disorder should receive attention as per the WHO Mental Health Gap Action Program 2010. And here comes our role. She will go to a psychiatrist. Psychiatrist will prescribe an antidepressant or a mood elevator. They'll get back to us asking us whether these drugs are safe in pregnancy. These drugs are absolutely safe in pregnancy, especially after 8 weeks. There is no reason why we should be stopping them from using the antidepressants, benzodiazepines, or any other mood elevators, which might help her a lot. And we should also be concentrating on the perpetrator of this trauma. We should try group treatment therapy for them, encouraging men to be accountable for their actions, take responsibility for their violent behavior, and training them to change their skill for reacting non-violently to others, and increase the awareness of what the dynamics are which are involved in the use of violence. We should teach them to change the attitudes on their belief around the use of violence in a relationship. To conclude, we should all understand that it's not only the physical aspects, not only what happened physically to her baby and what happened to her physically during her pregnancy. Her mental health is also important and needs to be addressed along with her physical health. I would again stress that please do the post-test and feedback at the end of this session. Towards the end of this session, we'll be posting the link for the post-test. Save that link somewhere so that if you do not receive the post-test link at the end of this, you can do the post-test through that link and submit your feedback so that your certificate can be generated and sent to your mail ID. Thank you for your patient hearing. Next, we'll be going to our next topic, that is challenging situations in violence against women and what is the role of self-care for us service providers in this aspect. I hand over to Dr. Susila for her next, Dr. Chandana for her next topic.
Thank you, Shailaja, for the elaborate talk. It was really good. How do we deal the mental issues? Basically, when a woman comes with violence. And also, how do we counsel the husband or the man who was involved in the violence also is very important. Thank you so much, Shailaja. Over to you, Chandana.
Thank you, Sushila ma'am. After having listened to Dr. Lata's and Shailaja's talks, since we have started dealing with these situations, that is violence against women, let's see how we have to take self-care of ourselves also. So when dealing with a survivor who may be feeling hopeless and might be having suicidal thoughts is the hardest of the jobs we have to deal with. And it in fact harms us also in a lot possible ways which we really don't realize. Suppose you're a gynecologist.
Chandana, I cannot view your screen.
Oh,
we can see the screen, but the PPT is not visible yet.
It's not opened. Challenging issues.
It's not open yet.
Lata, I think then you have to do it. I'm sharing the screen.
You stop sharing.
I'll stop sharing. Yeah, I stopped it.
Oh, yours is fifth one. No? It's visible?
Yeah, it's visible and the full screen is loading.
It's loading.
Yeah.
Yeah, we can see the full screen.
Thanks, Lata. Next slide. Next slide. Next slide. This slide.
Previous.
Suppose you're a gynecologist and one of your patients comes into your clinic telling that she's being threatened by her mother-in-law, who is constantly pressurizing her that she must divorce her husband because she's not able to give birth to a child. She feels hopeless and wants to give up. What would you as a gynecologist do, and what would you do? Can you do something to her? Please do share your views on the chat box given below. Next slide. So let's see some of the ideas, like how can we deal with such patients. First and foremost is you have to be able to recognize the signs of depression and suicidal risks in her, and never be afraid sometimes to even ask her, are you having a thought of suicide? Because if it is an yes, you have to deal with this case very seriously. And do not leave the suicidal survivor alone at any point of time, because she is in immediate danger. Always consult a supervisor about how to refer or manage a suicidal survivor, and never make a decision on yourself, because your safety is also at danger and your well-being is also in danger when you start looking at all such cases. So it's always better to refer them to a gender-based violence expert or an OSC expert for additional help whenever possible. Next slide. So as OB-GYN, should we ask the survivors that they have a suicidal tendency or not? So share your answer in the chat box and let's see what the answer is. Next slide. The answer is false, because asking about suicidal attempts or thoughts does not actually increase the suicidal attempts. On the contrary, talking about suicide often reduces the woman's anxiety in that particular situation, and she might feel like taking help from someone else. Next slide. So if the survivor tells you that the abuser has threatened to harm them, what should you do? It's better you work on this situation and you ask her what are the risks she is in, and you talk about all this in a privately with her, and what are the risks for her and how safe she is at home or workplace, and ask the survivor or help her out in making a plan next time. Suppose she is in such a situation or helpless situation next time, you can in fact make a plan for her wherein she could easily flee from that situation, and discuss the potential strategies for being able to leave her situation safely. And as I told you, provide a referral to the GBV expert or an OSC expert, that is one-stop solution, one-stop crisis center for additional help whenever possible. One of the most helpful techniques for helping a survivor to get out of an overly emotional situation is you should start asking her closed-end questions. Never ask her open-end questions. These closed-end questions will shift this emotional state of her into a cognitive thinking, and since they'll be very short answers, and you should make sure that you should not return to open-end questions immediately, because she should first start feeling comfortable and she should start getting some emotional control over her. So let's see what are some of the examples of these closed-end questions you can ask her. How many kids do you have? Are the kids going to school? And what are their ages? These are some of the closed-end questions wherein her emotional state will be shifted to a cognitive state. Next slide. So some of the challenging issues when dealing with a survivor who is mentally ill. Suppose you're dealing with a mentally ill patient, means already she is on psychiatric drugs which have been mentioned previously. The most important thing you have to do is you have to state clearly who you are and what is your role. Be always empathetic to her and not sympathetic, and be sincerely attending to her. Give her honest and factual answers whenever necessary. Never belittle her concerns. This is most important thing which we have to remember. And do not give advice as to handling their psychological problems. Don't deal with the psychological problems in her. Just act to that particular situation. And do not assume that these mentally ill people will know everything, or they know very little. This is not good for us. So, and always suppose this patient is really mentally ill, she's schizophrenic or something, you're dealing with her who has been abused at home, then you always have some emergency help in hand, and you should have emergency mental health backup for this patient also. Probably you have to talk to the, like Sailaja told, you have to stay in touch with the psychologist who has been dealing with her. Next slide. And some of the additional challenges which we might face is, usually what happens is when we start hearing about their stories, we try to get involved in it, we become sympathetic sometimes, and we try to involve the perpetrator, the relatives, family also, actually, who have been involved in this whole issue. Remember, never do mediation process. This is not at all recommended as a response to gender-based violence. Remember that the health workers are a part of the survivor-centered referral mechanism, and you should not do this at all. The mediation process itself maintains and contributes and sees and gives a positive signal to the abuser that he can use his ongoing power and control over the survivor. So mediation rarely results in an end to the abuser's violence, and it can actually lead to an increase in the violence. So, and also the survivor's rights are not at all respected. So never try to mediate situation. Next slide. Some of the safety precautions when dealing with these challenging cases are, multiple people can handle difficulty better rather than one person. So always remember to take help from a psychologist, general-based violence dealing people. A survivor, a service provider should never feel like he or she must work alone with a survivor. There are so many people, it's a multidisciplinary team which has to be involved. And always remember to establish a code word with your co-workers to identify those particular unsafe situations wherein you people who are working on it along with the survivor will only know about that code word, and you can use that in case of an accident or in case of that violence occurring once again. Always establish a relationship with the local police or a security also, and always you're also working in a very unsafe situations. So remember to have this buddy system at work, and also from to and fro from work also, it's better you travel with someone, and use supervision to address security concerns. That is, a group of people can address security better than you individually handling it. So as a healthcare provider, it is going to be very critical for you. Next slide. Do you know what is vicarious trauma? This is what we might land up in if at all more number of gender-based violence cases. Next slide. So let's see what this vicarious trauma is. You keep listening to their stories, you get involved in it, you get first you just get emotionally involved, then psychologically involved with the patient. So what happens? There is a change in the service provider's inner experience, and as a result of this emotional involvement with the survivor of the trauma and hearing to their stories, these changes occur in us. That is, we become physically, emotionally, and behavior states in us also keep changing, listening to these traumatic stories. Right? So sometimes we feel that we are powerless. Think that the service provider has no power or change the situation. So we always keep thinking, what has happened to her? Can't we change it? So we try to relate some things in our life which have happened. So we always feel that we are powerless. There is a helpless situation. We can't change the situation. So this all leads to so much of trauma in us. And this is what is called as vicarious trauma. Next slide. So how do we manage if at all we have landed up, or we know that we are going to land up in vicarious trauma? Is the answer to it is ABCS. Be aware, balance of yourself, and get connected. Awareness is knowing the limits, the emotions, and the resources, and try practice thing, self-acceptance. This is what most importantly is needed. And you try to balance the activities at work, at play, and rest. And most importantly, you take the support systems which are available, because taking support and communicating with the people around you who are supporting with you in dealing this situation will break the silence of this unacknowledged pain which you are going through. And this will prevent the isolation in you, and it will lead to validation and hope in you. Next slide. So what is next? Self-care. How do we take this self-care of ourselves? You have to create boundaries in workplace. Don't take it to home or put it around on your family members, and you establish support within the work environment. Seek assistance from outside agencies and create self-care plans for yourself also. Next slide. And always remember, when you're dealing with patients, most importantly, as it has been told before also in different presentations, be empathetic to these patients when you're hearing to you. When you're hearing to them, don't be sympathetic. So let's see what exactly sympathy and empathy are. You can just note down what the statement 1 and 2 are in your chat box. Statement 1 is a personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. So what is this? This is sympathy. Statement 2, an intellectual or personal understanding and professional distancing you will be maintaining with the survivor, and you will deal with compassion, and this will leave room for the empowerment of the survivor. This is empathy. Next slide. So do put in your chats in the chat box and start practicing relaxation techniques and self-care techniques for yourself. Next slide. Do remember to post your post-test and feedback at the end of all the talks. I thank Sushila Madam and Sailaja for this opportunity. Thank you one and all.
Thank you, Dr. Chandana. As Dr. Chandana told us, we should all understand that we should be empathetic towards the woman, not get sympathetic and overly involved and go into a position where we are trying to help her and we land in a position where we ourselves will need help. So be empathetic, keep your distance, see what you can do, don't get overly involved. And as she said, don't try to mediate, don't try to work on behalf of both the perpetrator and the woman who is facing the intimate partner violence. Next, we are going ahead. The next topic by Dr. Padmaja. Yes, madam, go ahead.
Can you see it?
Yeah, madam, it's loading.
Okay. Tell me when it ends. Don't tell me the system, huh?
Not opened yet, madam.
Still loading. Oh, loading lone unda. I think I have too many things on my desktop open.
The topic Padmaja madam is going to speak on is support systems, rehabilitation, and resources for survivors of violence.
Just a moment.
Yeah, madam, we can see your screen now, but all the icons are open.
Stop.
It's not coming out well. I mean, my system seems to have hung.
Shall I share the screen for you, madam?
The problem is, Lata, I can't see my own thing. One moment, I will log in again.
Yes.
Yeah.
Because sometimes these systems hang. Just give a moment. Can you see and hear me now? Lata, can you share?
Okay.
Yeah.
6th, no?
Next.
One minute.
You close
Next
off
one.
the others, Lata. 5 to 1 Navi. Fine.
Yeah.
Because otherwise, no, systems come down slow. That's what keeps happening with mine. Yes.
So your support system, no, madam?
Yes, support system.
Yeah, support systems.
We thank Dr. Anita, Dr. Jyoti, Rohan Palshekar, Ramani Garu for these slides that they have put in with a lot of effort. And you've been hearing about, next slide, please. You've been hearing about what are the types of, the violence and what is the trauma that the women go through and the long-term implications. So in this section, we are looking at what are the laws and acts, what are the helplines, and what is OSEC, one-stop crisis centers, and how do we help the rehabilitation by linking up with different groups. Next, please. The Domestic Violence Act was introduced in 2005. Next. It is before that in IPC 498A, there was a mechanism in which the male member or the perpetrators could be punished. But in that, there was no emergency relief, and all the remedies, the court proceedings were extremely protracted. And not only that, previously, a relationship only in a marriage was recognized. Next, please. So with this Domestic Violence Act in 2005, it has increased the scope. It is a civil law. Here, a case can be booked against the husband and only the male members of his family. Here, the wife or the female partner, it could be anyone, like how in the MTP Act, we say any female partner can be, undergo a termination. It does not have to be a married woman. In this, we are recognizing the changes in the society, and we are saying even a female partner, even if they're not married, they also get relief. But unfortunately in this, unless the husband violates a court order, he's not going to be directly punished because it's a civil law. Next, please. So who can complain? A wife, of course, and a woman who can complain against a male abuser in a shared household. They might be sharing it because it's a consanguineous relationship, like or an adoption or a cohabitation. A woman who is in a relationship that is similar to marriage, or she is in a live-in relationship with an unmarried man, or a married man, but she did not know he was married. So these are the people who can file. So it basically gives women, it defines women in a relationship with a man in various different ways. And in fact, it goes on to say a transgender who converted from a male to female can file against a transgender who is behaving as a male. So, and anyone with the survivor's consent can also file a petition. Next. Against whom can you come, to whom will you complain? You can complain to a protection officer. You can complaint to a service providing center officer, medical officer in charge, police station, or a magistrate. Next, please. And where can you complain? That means the place where you can complain, where the woman is, where she is working, or permanently or temporarily, against a person, man, who is residing temporarily or permanently, or wherever the action has taken place. And so the lady can choose any of these three options. So it covers almost everything, because it's a permanent residence, it's a temporary residence, it's a place where it is perpetuated, or in a place that they are together. Next, please. And what are the types of orders that come? Protection orders will be there. Immediate action to stop violence will be there. There will be an emergency release. And if it is a shared household, the woman, whether she has a right or not, she can claim part of it because she's been living in that place. The woman can also ask for a separate housing, which the abuser must provide. There will be custodial order regarding the children. There will be a compensation order. And any violence of these, the magistrate can then charge the male person as an offender. Next. So non-compliance of the protection order by the magistrate will lead to a non-bailable warrant. So initially, although they did not put that it is a non-bailable warrant, but once there is a woman complains, she is given a protection, and if that is not followed, then it becomes a non-bailable warrant. Next, please. And the beauty of this is the following the application within 3 days, an action must be taken, and all proceedings should be disposed within 60 days of the first hearing. So this, we believe that justice denied, delayed is justice denied. So in this, if it is Prevention of Violence and Domestic Violence Act of this 2005, it gives a fixed time frame for women where they can get justice. Next. And the services order offered in this are that a detailed investigation report will be filed. The compliant, whoever is suffering, they can be given a shelter. Facilitation of the legal services occur, and counseling services also. Next. So what are the remedies that we have? We have the Dowry Prohibition Act. We have a Women's Commission that is set up. Although 498A IPC is most commonly used, now this prevention of protection of women from domestic violence is there. And in the Constitution of India, Article 14, we all have a right to be treated equally, all citizens. Next. So the concept of OSEC, or a one-stop crisis center, is that it provides immediate relief, legal, psychological issues of people who are survivors of physical or mental abuse, with the assurance that their consent and confidentiality will be respected and protected. So there are 234 centers all over the country. Next. And SHE teams are available in Hyderabad. It's a very well working thing. I think even here we have. So the helpline, if we call up 100, then we will be directed to center Bharosa if there is violence. Next. And these are the numbers that you need to note down. Next slide. As a child helpline is 1098. In this, women are 1. So 1091. That is the number for All India Women Helpline Distress. Domestic abuse is 181. And we need to keep the numbers of the, you can take a photo of these, National Commission for Women. Next. And AP has a Bhumika Women Collective. Today morning, just before I was doing this talk, I had given them a call to find out whether they do respond, or is it just we are giving a talk and telling people. They do respond immediately within the 3rd ring. So we can keep this number and give it to women. Next. And these are all. So you've already done the registration. So please do give us complete the post test and the feedback. And these numbers, I think we need to write them down so that we can help women in the rarest of rare conditions if we come across them. Okay. Thank you, Lata.
Thank you, Padmasha madam.
Shall we go on?
We'll go ahead with the next topic, madam. Sexual
Yes.
violence, how to approach a woman who is facing sexual violence.
So Lata, you're helping me out with that also, na?
Yes, ma'am.
Today.
Padmasha, will you do
Yeah, I'll finish it and go.
Yeah, okay.
Padmasha madam, there is a question in the chat box.
Uh-huh.
Dr. Srirama Prasanna says, all said and done, in my 40 years plus of OBG practice, I have seen 2 pregnant ladies who had malified intention to hook their husband's family members with 498A by sprinkling kerosene on themselves just because they didn't want to be in the combined family. How to deal with such spurious violence?
For us, see, madam, the problem is that we will see, okay, this is a tip of the iceberg. So some people with bad intentions might be doing it, but most of the women don't do it. So just because someone has done it, it is not our responsibility to find out the truth. Our responsibility is to report it, and it is the responsibility of the police to find out the truth and the inquiries. Our responsibility is to be there for women. Okay.
Yeah.
Another question is, madam, is it mandatory to report to the police if we come across a woman facing violence?
It's not mandatory. It is always only with the women's consent that we can go ahead. But remember that it is mandatory that we support our women and encourage them and tell them that these are the venues possible, and talk to them about the possible consequences, because the cycle of violence is going to continue. No one is going to really, someone who was a calm person, who's a okay person, he's not going to turn violent all of a sudden. So the cycle of violence is going to continue. So at some point of time, the woman needs to take a step, if not for herself, for her children.
And do we document what we have spoken about this act of violence and what she has answered?
I think it is ideal, because we will forget and later we will be called to be witnesses. So at least in a different place, confidentially, you can write it down. You can't write it down on the case sheet because we are trying to maintain the confidentiality. Okay.
Thank you, madam.
Thank you.
Please go ahead with the next topic. This is how to approach a woman who is facing sexual violence.
Okay, we thank Dr. Jyoti for the slides, which have been hard work has been done by Kiranmai and Mr. Ajay. Next slide, please. So what exactly is sexual violence? It is an act or an attempt to obtain a sexual act. So it does not have to be a completion of the act. Any unwanted sexual comments, acts to traffic directed against a person's sexuality by coercion, regardless of their relationship to the victim, in any setting, that's at home or work. So this is a very broad term. I know, as it was said, that it can be misused, but I think men also need to recognize that there are boundaries in which women are comfortable, and they just can't say that she's sensitive, because if she is sensitive, then they should be maintaining the boundaries even more strictly. Next, please. Rape is the most violent, and this is forced or coerced intercourse. But it does not mean only a penetrative intercourse of the anus or the vulva with the penis. Using any other body part and any other object will also come under rape. Next, please. So rape does not mean that we always find semen in the vagina. So even a penetrative thing, even when an object is used, it can still be considered rape. The chances are that we all have know someone who's been sexually assaulted, because almost 40% of women in our Southeast Asia have been victims of sexual violence at some point of time or the other. The unfortunate thing is victims usually know their assaulter. And as we were saying, it is not the fault of the victim for being assaulted. It is the fault of the perpetrator. They had no right to violate her. Rape is least reported and it is the least convicted violent crime. Sexual violence can be preventable in most of the cases. And that's the reason we are doing the Dheera child program. And we need to know that help is available. Next. So what are the types of sexually violent acts that take place? Rape can be within marriage. It can be in a dating relationship. A lady might be in a relationship with a man, but at some point of time, she always has a right to say no. If in that particular day, she says no, and she's still forced, it is still considered rape. Rape can be by strangers, and rape nowadays, unfortunately, occurs in armed conflict areas like in the Middle East, in Ukraine. The worst form is sexual abuse of children, and not mentally, even mentally and physically disabled people are being sexually abused. And unwanted sexual advances and harassment, including demanding sex for in return of favors, is also sexual violence. Next, please. And some forms are like forced abortion, forced prostitution, genital mutilation. And if someone says they want to test a woman's virginity and force her to have an obligatory check for virginity, even that is violence. Denying a woman the right to use contraception, protection against sexually transmitted also constitutes violence. Marriage of children and forced marriages are also violence. Next, please. Quite a large number of times, young girls are married off in many parts of the world, including us. And this is, people think it is okay in a young girl, just because she's married, that she can be, they can have sex with her. And why we consider it a sexual violence is children are unable to give or withhold their consent, and majority of them know little or nothing about sex before they're married. Next. So the consequences, you've already heard: the physical, the pregnancy and the gynecological complications, the sexually transmitted disease, mental health issues, suicidal behavior. And if they say, quite a large number of times, they're socially outcast. So the fatal outcomes are homicide, age-related, and suicide. Next. The non-fatal are that there are unwanted pregnancies, chronic pelvic pain, sexual dysfunction, sexually transmitted diseases, and sometimes that leads to infertility. There can be urinary tract infection, gastrointestinal disorders causing obesity, anorexia, migraines, frequent headache, fatigue, feeling of tiredness, nausea, and other gynecological pregnancy complications, along with the psychological issues of rape trauma, post-traumatic stress, phobias, denial, fear, confusion, anxiety, guilt, and depression, alienation, increased substance abuse. So when we are approaching a woman with a sexual assault, the trauma-informed care approach should be utilized, where we look at neurological, biological, psychological and social effects of this trauma and violence on the individual. And so triaging the patient when they complain of a sexual assault is very important, and that's a medical emergency. Next. So what we need to do is the medical and psychiatric evaluation and stabilization, community advocacy, report as the state statutes say, and conduct the examination if desired by the survivor. And as we said, if the survivor says okay, only then can we talk to the law enforcement. But prophylactic medications for STI, STD, and pregnancy risk evaluation, these can be given always. And we will be called as expert witnesses either then or later. So we have to have this medical and forensic care and write it down carefully. Next, please. So in this trauma-informed care of the patient, what we need to look into are the safe, to assure them that it is safe, we are trustworthy, that they always have a choice. We will do anything only in collaboration, and it is in their power to move ahead. Let's look at these aspects. So always knock on the door before you enter the room. talk to the woman or the patient, whoever, the patient, the child, whoever it is, before they disrobe. Only disrobe what is necessary and partially disrobe. Clearly show them the washrooms. Take time where you can familiarize the person with the physical environment. Adjust the lighting, not too bright, not too dark. Show respect and warm, compassionate manner to build up a rapport. Next. And explaining all these procedures in the terms the patient can understand, telling them what to expect, how long it will take, asking them if they're okay with it, if every point will prove our trustworthiness to them. Next. So they always have a choice. So before we touch, every time we need to ask them. Before we call in additional staff, we need to ask them. Sometimes they get scared in claustrophobic enclosed spaces. Ask them if you can close the door. Let them decide where they want to sit in the room. And for each procedure, if you tell them why we are doing it, they're usually more comfortable. Rather than them understanding, our continuous reassuring voice will help them. And we need to take consent for each part of the examination. Next. And talking to them first, what are their top worries and concerns is very important. And we need to share what we are finding. As we are doing, we can say, okay, fine, I think this is bruised here. Was this bruise present before this event happened? So we can also encourage them to help take decisions about the treatments. Next. And this is one of the most putting down events of sexual violence. So we need to give them that sense of empowerment by asking them what happened, taking time to listen to her so that he or she feels genuinely heard. And when we are doing it, is this okay? So before we start the procedure, during the procedure, ask them what will make it easier to examine, and paying attention to their body cues, because sometimes the survivors, if they have been repeatedly sexually assaulted, they're so conditioned not to defy authority that even if they're undergoing a distress during procedure, they don't speak out. And this is on the top, very, very bad for them. Next. So in a sexual history, we need to also ask about the medical history, and we need to ask about recent consensual activity. So if they've had sex even a little before, we need to know. Previously, it could have been consensual also. Assault-related medical history, details of the assault, nature of the physical assault, after the assault, what happened, and do they have any information about the suspect? Next. So do complete your post-test and feedback. And I think Dr. Susila is going to take you through a detailed how the examination and collection of evidence is. We were told by the teams previously, as I was telling you, the conviction rate in rape is extremely less. Not even 2% are convicted. That is because the gathering of the evidence at that point of time and writing down clearly and being bold enough to document everything that we see. We don't have to say we think this girl was raped. We need to document the bruises, the injuries, the trauma that is there, so that that will stand up in a court of law and the rest of the and justice can be done. Thank you, Susila. Thank you, Selja, for coordinating.
Thank you, Padma.
Thank you, Dr. Padmaja, for that elucidate description of how do we approach a victim of sexual violence. We'll go ahead next with the last topic being handled by Dr. Susila. How do we examine the survivor and collect evidence? The most vital part to make sure that the perpetrator gets convicted, as Dr. Padmaja said.
So coming to the last topic. So thanks Padmaja and Shailaja for the introduction. And as medical experts, I think we all should know what we need to do when a survivor comes to us. We need to examine them, and we should have the minimum knowledge, at least how to go about it and how do we document it also. And this helps to derive and arrive at a particular diagnosis too. So the role of the gynecologist is to use the important evidence of crime, help the judges understand the physical and mental condition of the survivor. And also this helps to report, to corroborate the survivor story and enhance the credibility. and offer the primary level counseling treatment and refer to the physical and psychological sequences. So on the whole, we help the woman to get justice. So the first part of it is the medical examination. So before even starting the medical examination, we need to take informed consent, then go ahead with the recording the history and documentation of the injuries. And also we should have the talk to them about the nature of the sexual violence, the time elapsed between the incident and the examination, whether the survivor has bathed and washed the evidences out. So we need to talk to them regarding these. And in Government of India, there is a book regarding the how to examine the sexually, that is the women who come with the sexual violence. So 1 to 11 are the general instructions, 12 is informed consent, 13 is a mark of identification, 14 is a relevant medical and surgical history, 15th is history of the sexual violence, type of the physical violence, whether it is an emotional abuse, etc., general physical examination, examination of injuries, and external genitalia, systemic examination, 20 and 21 regarding the evidence and sample collection, provisional medical opinion, that is what is that we conclude to, or what do we have to write, and treatment prescribed by us, date and time of completion of the examination, and finally our opinion. So first is like we have to fill the form, name of the hospital, her OPD number, and then like wife of her daughter, her address as per the Aadhaar card, and age as reported, and be sure that it is on her identity card. Sex of the patient, that is we usually tag the girl or the woman, so we have to write write down, and date and time of the arrival. When did she arrive, and when did we start the examination, and she was brought by whom, whether she was brought by a police or an attendant. And already if she has, like the police have brought, we need to enter the MLC number and to which police station the case belongs to, and whether she is conscious, coherent at the time of examination, because it is most important thing. We need to have an informed consent from her if she is a major, and any physical or intellectual or psychosocial disability, that is, is she a mentally retarded or any other problem is there, and if she needs an interpreter or a special educator if she cannot talk to us, like if she is a disabled person, like hearing disability or speech disability is there. So first thing we have to, after the consent, we have to do the medical examination. If she be specific, like whether she has consented for the medical examination or not, whether she has consented for the medical legal examination, and sample collection. Also, we have to tell her what all we are doing to her, and also understand that as per the law, the hospital is required to inform the police, and this has to be explained by the doctor to the victim. And I want the information to be revealed to the police, that also we have to talk to her. And I have understood the purpose and the procedure of the examination, including the risk and benefit, explained to me by the examining doctor, my right to refuse examination at any stage, and the consequences of such refusal. This is all she has to read. The victim has to read and sign for us. If special educator or interpreter is along with her, we need her name and signature too. So we have to explain the woman in her language, in which she understands, and then take the informed consent. So how do we write about the marks of identification? Any scars or moles? And important thing is the left thumb impression. And relevant medical and surgical history, that is the onset of the menarche, age of the onset of the menarche, and menstrual history, cycle length, duration. When was her last menstrual period? And then is the incident taken place during her menstruation? Or when we are examined, is she in her cycles? And was the survivor pregnant at the time of the incident? If so, what is the duration? And is she using any contraception method? And if so, what is the method she is using? And what is her vaccination status? Is she being vaccinated for tetanus and hepatitis B? So when did the incident take, whenever we take the history of the sexual offense, the first thing is the time of the incident, where it has happened, and whether it was like the duration of the sexual offense, that is within 1 week, or it is within a month or 6 months, we have to document it, and whether it is a single episode or it is the multiple episodes or it is a chronic one. And number of the assailants, their names, the sex of the assailants, approximate age, any assailant is a relative to her, and the description of the incidents in words of the narrator, not in words of the doctor, but it is in the words of the narrator. The narrator of the incident, that is, if anyone is there along with her, we have to write the name of the one who is along with the patient, that is the name and the relationship to the survivor. If anything extra is needed, we can add a page to all those things. And then what is the type of the physical violence used, whether it is with beating with a hand or a fist or a blunt object or a sharp object has been used. It was like pulling of the hair, banging on the head, dragging her, biting, pinching, or a violent shaking, anything, whatever like the patient narrates, and we need to just stick in the columns, in the blocks. So is it as emotional abuse, or any weapon has been used during that abuse, and only is it a verbal threat using like photographs or blackmailing her or luring her with the sweets, chocolates. Usually the young girls, adolescent girls will be loaded with the sweets, chocolates, drinks, alcohol, etc. And any kind of other emotional abuse has been there. So any history of alcohol, or is she under the influence of alcohol or drug intoxication, or whether she was sleeping or conscious at the time of the incident, or if the survivor has left any marks of injury on the assailant. So whenever the rape, like any sexual abuse has happened, probably she must have scratched the victim. So at least we should ask whether she has done any of the harm to the assailant or injury to the assailant. And details regarding the sexual offense have to be filled, where what was the organ involved, whether it was any object or any, it was with the penis, or it was with the fingers, etc. We should ask her, and whether there was any emission of the semen, that is any ejaculation has been done. And then if it was an oral sex or anal sex, we have to talk about it, and then we have to complete this form. And regarding the details of the sexual violence, like it was a forced masturbation by the assailant, by the survivor, or it was simply an exhibitionism, or ejaculation occurred outside the orifice, if so, where on the body, whether a condom was used, whether it was the condom was intact or not, any lubricant has been used. And then all these things have to be included. Just we can tick each and every one. If it is no, also we can just mark it as no. And post incidents detail is very much useful, like whether she has changed her clothes or undergarments, or cleaned or washed the clothes, or whether she has bathed, doused, passed urine, etc. have to be asked, and we need to fill all the forms, and the time since the incidents have to be mentioned in the columns. And then history of any bleeding, oral bleeding, vaginal, anal bleeding, or any discharge or painful urination or painful defecation, any fissures, anal fissures, or abdominal pain and pain in the genitals have to be marked again in this column. So coming to the general physical examination, we have to mention the height in centimeters, weight in kgs, the build of the women, gait, and also the pulse rate, whether like is she okay or is she stable or not, we have to see. And blood pressure, temperature, respiratory rate, pupils, and any disability or disformity have to be mentioned. So coming to the examination of the injuries, what are the types of the injury that we are seeing on the women, where are they, and then what is the size, shape, colors of it, we have to mention. So whether it is a bruise or a nail abrasion or a teeth bite, cut, laceration, any fractures, any tenderness, boils, burns have to be mentioned. And then at what place, whether it is on the scalp, face, breast, shoulder, wrist, forearm have to be mentioned. And what is the size, that is in centimeters, the shape of it, whether it is like ragged edges are there, any color, like redness is there, any swelling, whether it is a past one, any signs of healing, is it a simple one or a grievous one? All these dimensions have to be mentioned in the form. So the external, after taking the consent from the victim, we need to examine her labia majora, labia minora, urethral meatus, vestibule, fourchette, introitus, perineum, hymen. When we examine all this, we have to mention the type as I have told in the previous slide, that is whether there bruise is there, any nail abrasion, teeth bites, etc. we have to mention, and also the dimensions of the wound, and per speculum examination finding, PV finding, if we do it. Usually the per vaginal and per specular examination should not be done unless required for detection of injuries. If there are no injuries, there is no need to perform the 2-finger test. If we do it, why we have done have to be mentioned in the it has to be documented. And then in case of any bleeding, tears, discharge from the anus and rectum, we have to do a per rectal examination. In case of bleeding, discharge, tears, and edema are there in the oral cavity, we need to examine, and also we need to document on the form. Systemic examination includes the CNS, CVS, respiratory, and basically the abdominal examination. If there are any bruise or any trauma is there, we have to mention, document it. So how do we collect the evidences, and what is the purpose of it? Is to obtain the confirmation of allegation, to establish the link between the victim and the scene, and to establish the link between the victim and the assailant. So all this is needed for confirmation of the violence, and also whether it was a simple one, whether it was a grievous one, and what type of the punishment the victim is going to face depends upon all the evidence and collection of the samples. Every contract leaves a trace. So we need to meticulously examine the woman for the injuries, and always maintain a chain of evidence. Identify the specimen. That is, we have to properly label. Whenever we collect the evidence, we have to label the specimen and sign it to, and record the disposal of the specimen. So we need to record it. We have to, first is identification, then labeling, then signing, and then recording. All these things have to be in a chain. And we have to ask for the laboratory investigations like blood for HIV, VDRL, HBsAg, HCV, urine for pregnancy test, ultrasound for to confirm the pregnancy if any, or any internal injuries like bleeding, and X-ray to rule out any fractures. For the forensics lines laboratory, we have to collect the debris, and also the clothing. They have to be packed in separate paper, and after air drying, everything has to be packed and submitted to them. So the swab for sample collection includes the swabs from the strains on the body, that is blood, semen, foreign material, scalp hair 10 to 15 strands, and we may do the head hair combing also to obtain it. Both we can obtain the victim and as well as the assailant hair also can be obtained from this. And the nail scrapings from both the hands separately, we have to mention it right and left. Oral swab has to be taken, and blood for grouping and testing for alcohol, that is the is she under the influence of the drugs or is she under the influence of alcohol, blood for DNA analysis, and urine in case we suspect any, if she is under any drugs for testing, and tampons, sanitary napkins, and condom objects have to be also have to be like collected. If not collected, so we have to mention why they were not collected. If we collect, that is okay, we need to document. If we don't collect, we have to mention the reason. And we also have to collect the matted pubic hair, and pubic hair combing has to be done. And if it was shaved, we have to mention it. And cutting of the pubic hair and mention if it has been shaved. And we have to collect 2 vulval swabs for semen. One is for semen, one is for DNA. 2 vaginal swabs, one is for semen, other is for DNA. 2 anal swabs. So we have to collect 7 swabs actually. Other one is the urethral swab, and 1 smear from vagina. And it has to be air dried for semen examination. Samples have to be preserved as directed till handed over to the police along with the duly attested sample seal. So we have to collect them, and then we have to document them. We have to sign, and then everything has to be packed and till the police collects from us. If not collected, we have to mention the reason why we have not collected. And all the samples have to be packed, sealed, labeled separately, and to be placed in a bag. All these genital and anal evidences. And we have to give our provisional medical opinion. That is, I have examined so-and-so person, so-and-so age, and then reporting the type of sexual violence and circumstances, and at what time, date. And then also we have to document that whether she has bathed or doused and for how many times she has done so. So my findings are as follows. like we have to report in this format. That is, what are the samples collected for the forensic lab and for the hospital laboratory, and clinical findings, what are all those we have to mention, and what are all the additional observations. So our findings will be in this form, in the, like we have to opine. And coming to the treatment aspects, we have to give the treatment for the sexually transmitted diseases prevention. That is, we have to give her the antibiotics, if needed, antiviral. Emergency contraception, that is, we have to give her the levonorgestrel if she comes within 72 hours. In case of the wounds, dressing has to be done, tetanus prophylaxis, hepatitis B vaccination, and post-exposure prophylaxis for HIV. If we know the status, or if we don't know the status also, we are supposed to give the prophylaxis for HIV, post-exposure one, and counseling has to be done, and any other thing we need to document. And again, we have to mark across all this, yes, no, any comments. So date and time of completion of examination has to be mentioned, and we have to report how many forms we have documented, within how many forms did we submit, and the number of envelopes, because we keep all the sheets in the envelopes and then enclose them. We have to clearly mention the number of the sheets, number of the envelopes, put a signature, name of the examining doctor, and also the seal has to be placed. So the final opinion is like after we get all the lab reports, then the opinion regarding sexual assault survivor to be given in the case of sexual assault or rape. So we have to, like, I'll just show you. There are 11 in the next 3 slides. There are 11 things we have to talk about. There is evidence of recent sexual intercourse, and that is when we have to opine this. When the recent injury of the genitals and other body parts are found and motile spermatozoa are recovered from the vagina, then definitely there is a recent evidence of sexual intercourse. Suppose there is partially healed injuries and non-motile spermatozoa in the vagina, then we are reporting, it means that it is remote from sexual intercourse. And local recent injuries to genitals, but no spermatozoa are recovered, and the condoms are there, like condoms have been used or vasectomized, or other objects have been examined, then there may be a recent penetration. So we have to document as or opine as there has been a recent penetration, because recent injuries are there, and then even though the spermatozoa are not there, but local recent injuries we have seen on the genital, probably there is a recent penetration. And when there is, and the 7th one is important, when there are no injuries, no spermatozoa are recovered from the vagina, there is no evidence of penetration, vaginal penetration, but possibility cannot be ruled out. So this we have to mention if there are no injuries, no spermatozoa. So whatever we write in this, if we go through all these 11 columns, then we can arrive at a proper diagnosis to say. So again, when there are no injuries, no spermatozoa are recovered from the oral cavity or anal, when they complain of oral sex or the anal sex, then we can write there is no evidence of oral or anal penetration, but possibility cannot be ruled out. So findings in support of the above opinion, taking into account the history, clinical examination findings, laboratory reports, we have to opine in this pattern. That is, I'm of opinion that. So the last 11 columns which I have shown have to be written in this part of the document. So we have to sign, we have to name, put our name here, place and put a seal, and copy has to be given to the survivor, the victim free of cost immediately, and also to the police. So in summary, take an informed consent. Per vaginal examination, 2-finger test need not be done, and the hymen or the size of the vagina need not be commented upon. Only the injuries we need to comment, and the sample collection has to be perfect, and we have to give the final opinion after we get the report, lab reports. And this is a summary of what I have told, and we have to dry pack all the wet part, even if it is a swab, we have to dry it and then pack it, and we have to follow up the patient, and we have to go for the in case of sexually transmitted disease prophylaxis, HIV prophylaxis, emergency contraception, UPT, all this have to be done, documented. So, all these things have to be there, like shoe covers have to be there, cap, etc., filtered paper, sterile swabs, hand wash, all this have to be there with us. And then for the plastic size of the plastic bags also to enclose them. All these things we should know what all we should have before examining a rape victim or a sexual assault victim. So we have to acknowledge the hard work of the total Dheera project coordinators of OBGYN. And the other important thing is that we can go through in our websites like guidelines and protocols of medical legal care for survivors, victims. This is from the Ministry of Health, a 100-page one. And I think we can just go through that before we get a proper knowledge out of it. And this is an overview of all those 100 pages to say. And there is also one of the video on the YouTube by Dr. Ponnuru Malati. She's from Hyderabad, and helping the Telangana Women's Safety Wing. And this is the overall view, and requesting you all to complete the post-test and to get the certificate. Thank you, one and all.
Thank you, Susila Madam, for such meticulous description, so that the perpetrator is booked and the victim gets justice. Before we go ahead, let me tell the participants who are still logged in, there is a link in the chat box regarding the post-test. Just go through that link and do your post-test and feedback for your certificates to be sent to your mail. Madam, we have Dr. Manikirao appreciating that your talk was very good and well-organized program. He's asking, do we need to intimate judiciary or not? Can a private doctor examine the victim? And do we disclose the identity of the victim or keep it a secret, which are common doubts for the young doctors?
Yeah. The first thing is, do we need to intimate the judiciary or not? We are supposed to actually definitely inform the police. So we have to fill the MLC form and then inform them once they come. That is when we have to start the examination. So whenever somebody comes saying that the sexual, they are the victims, then we need to do an MLC. After the police comes, then only we are supposed to go ahead with the examination part of it. Only thing is we need to examine, and the rest of the thing is the work of the police, not like judiciary. There is nothing to inform to the judiciary. Okay. First one is that. And then in case if she is a child, then we have to call up the child helpline too, apart from the police. And then because she comes under the POCSO Act. And other one is, can a private doctor examine? Yes, we can examine, and then we are supposed to know all this procedure, and everybody should have the kit to examine whenever the victim comes to us, and we cannot deny. And suppose if the victim chooses your hospital or she chooses you specifically, then we have to go ahead. We cannot deny. That is what we all should know. And other thing is
identity of the victim.
The identity of the victim should be disclosed or kept hidden. And there is nothing like we should disclose to anybody. Any MLC case, I don't think we really disclose. We just inform the police. That is our duty. Okay. And common doubts. Okay. All these are the common doubts. I think whatever is needed is that we need to examine, help the woman out, inform the police, do the documentation properly, and come to a final diagnosis. And then be specific. Out of all the 11 columns in the opinion form, we have to fill the think about it and fill it. Whether it was a recent one, it was a past one, whether there's any possibilities there. So whenever we follow all the documents, I think putting a tick or putting yes or no, we do a proper justice to the girl.
And wouldn't it be safe for us to keep a copy with ourselves when we are called back to court?
Yeah, definitely. And the only thing is we need to attend the court. I think any MLC form, we are attending the court. So we need to, like any other consultant, suppose it's an orthopedician, he handles a trauma case. If it is an MLC case, he goes to the court. Like that, even we should go to the court whenever we examine. It is all for our women. So we should not be afraid to go to a court and then tell our opinion. We should be bold enough. All the private practitioners should be bold enough to take up the cases. So because we see many branches, they take up neurosurgeons, physicians, and all these people, they take up all the MLC cases, poisoning cases, they do handle them. And then why should we not go to the court and then help the woman out?
Thank you, Susila madam, for that clarification. Shall we wind up, madam? There are no more questions in the chat box. I hope all of those present have copied the link which is in the chat box somewhere so that you can go through it later if you are not doing it now.
Yeah.
Shall we wind up, Susila madam?
Yeah. We'll call a day. The basic thing is we should all know what are the documents needed, how we go about the examination, and also help basically whenever a woman comes. So this is not only for just examining a sexually assaulted woman, but also whenever they come for an MTP, she doesn't want to undergo an abortion, but the family really is behind her to go for an abortion, all these things. At that time also, we need to help her out. Yeah. Wind up the.
Thank you, Susila madam, for organizing this Dheera OBGYN program. We had 93 people logged in maximum at a point of time. And the various topics for which we usually have doubts when we come across a woman who has faced violence, I hope they have all been clarified and there is some clarity about how we go about it, how we examine the case, how we collect evidence, and how we have to address her mental issues also, how we should have empathy towards her and not sympathy. We should not get overly involved. We should keep our borders. We should know how to inform the authorities and how to help her out. Never try to mediate between the perpetrator and the victim, and don't be standing on both sides. And thank you, Sriman, for being with us throughout the session and handling it. And thank you to all the participants who made this program possible. Thank you, one and all.
Sperms found in the sample, but DNA.
And there is one more question in the chat box.
Yeah.
If sperms found in sample, DNA not mentioned, what to do?
No. The thing is, our duty is to collect the samples and hand over. Okay, whether it is a recent one or it is a old one, or a possibility is there. It is nothing like we talk about the DNA, etc. The sperms are found. There is a penetrative act. There is it is a recent one. That is what we need to mention, Dr. Radha, I think. Udayagiri Radha. Yeah, that is what we need. Rest is for the police. Rest is for the police. And the judiciary to take over. Yeah. Thank you so much for logging in and also the interactive session. Thank you so much. Thank you, Shriman. Thank you, Shriman. Yeah.
Thank you, Sriman, and thank you to all the speakers, Dr. Lata, Dr. Padmaja, Dr. Chandana, the master trainers. Any doubts, we are always available to clarify these doubts. And Dr. Sujayasree says, thank you, WOBS team. Thank you, madam. We are winding up.
Thank you, Sujayasree.
Madam, those kits, are they readily available?
Yeah, they are available. They are available actually. I'll just share the number with you. So the kits are available.
Okay. Ma'am, share it in our OBG group, ma'am, so that everyone.
Sure. Yeah. And also I'll share the guidelines Ministry of Family, Ministry has given us, Ministry of Health has given us. I think we need to go through because as the victims are increasing, we don't know who's going to choose us. And then we cannot just say no, deny.
Okay, madam. So all can close the session.
Duttu.